So I think that, fortunately, because of things like the human rights frameworks, as well as the focus on particular groups like indigenous people, women, of course, girls now coming out more clearly.
Were there LGBTs in 1994?
I think that, okay, this is very interesting. So yes, indeed, the LGBT agenda, I would like to be bold and say, yes, there was an LGBT agenda in the 90s as well. I think within the ICPD framework itself, it actually recognizes the different forms of families, so it is not just the heteronormative family alone that is included, but plural families, extended families, including single female-headed households, and of course same-sex families as well. So I think that was there. Definitely in Beijing, I think that giving women the right to determine their sexuality, was also part of that. I think the word sexual rights itself was discussed in ICPD in 1994 and 1995, but governments disagreed to include that language. So I think LGBT was always around. It is just that...
biblical times.
Yeah, so it is just a matter of forcing them and looking at them as deviant is perhaps new even in our own cultures, because we did not, the Malaysia of the 1970s and 1980s was a far more accepting, tolerant society as compared to, I think, there's a greater deal of conformity that is forced. So you may ask that, perhaps link it back to that rising conservatism, right? Who is affected by the rising conservatism? Rising conservatism actually, in my opinion, affects poor women, the lesser educated, the lesser wealthier, those of different sexualities, sexual orientation, simply because these are the ones where they have fewer options, right? For example, if we look at family planning for unmarried people, young people who are wealthier, who are educated overseas, have already got access to family planning regardless of their marital status. It is the poor ones who are living in rural areas are unable to go to the family planning clinic and get the services, right? So I think that we need to really say that if we were going to make the mark of morality punishing poor women, rural women, lesser educated women, then we really have to question whether that's really moral or not.
So let me ask Annette the last substantial question flowing from this, and then we'll wrap the panel with just very quick thoughts. So we as the UN, founded by the Charter, the Declaration of Human Rights, as you also said in your speech earlier, how do we at this point, 25 years after ICPD, how do we in a way regroup, if you will, and really ensure that we are doing what we are meant to be doing? I know that's a bit of a tough question, but as UNFPA, which is perhaps a more quote-unquote activist agency, if you will, because we do advocate for these issues that others don't always want to touch, where do you see us today as compared to, say, 25 years ago, and where should we be going forward?
I think there were two questions in that. What should we be doing as the UN, and where are we now, and how do we go forward? And I think from looking at it from the lens of the regional office where I'm sitting, we see large differences between countries and large disparities between countries, not just within, but between. And I would say that there are countries that we cover, like Afghanistan, for example, that have a prolonged conflict in which the marginalized group have remained marginalized, and women and girls are very much struggling to realize their rights, not just basic human rights, but also in sexual and reproductive health. And so access to sexual and reproductive health care is difficult. But they have, and what is changed, or what is evident, is they have some real activists amongst them. And they have some real, very strong women who have been working on these issues for a very long time. So for the UN, it is important for us to not come in as a Western organization or Western perceived organization, but to really work with our national advocates who have been there through thick and thin. I think of, say, for example, Dr. Nazrin Orakil, who was a former Minister of Social Welfare. We worked with her around, and then she was also the director of the Fistula Hospital. We worked with her very, very closely around trying to ensure that the most marginalized received fistula care. Now, fistula, probably most of you in this room have not heard of obstetric fistula, but it's basically a condition that happens in the most marginalized because these women do not have access to emergency obstetric care. And what actually happens is because of obstructed labor and prolonged labor, their uterus, their vagina, and their rectum get ripped or torn. And so the surgery that's required to actually heal this and repair them is very difficult and takes a long time, and these women become very, very marginalized in their own families. So I know that there's been a lot of progress in Malaysia, but in many countries in our region, we're actually seeing progress happening at a much less pace, and certain marginalized groups do remain marginalized. And so for the UN, for us, we have a certain moral obligation to ensure that we lift all women, regardless of what country they're in, but particularly those that are furthest behind, that we lift them even more, and that we put our emphasis and focus on these particular groups. I don't know if you want me to carry on. I think that from the point of view, and I think Dr. Narimah already mentioned it, is the issue of humanitarian situation. And I think these are a group, as we see more and more the humanitarian situation revealing more frequent disasters, more displaced women and families, that we ensure that the essential package of sexual and reproductive health is delivered to them, but also that women are supported to be able to be free from violence that is often used as a weapon of conflict or a weapon of war. And I think that these are some of the issues that we haven't really talked about, but it is evident that there are some very marginalized groups amongst these groups. And it is also, we also know that the majority of the maternal deaths in the world are actually happening in countries in which there's ongoing conflict or in which there are humanitarian crises that occur.
Thank you. So we could, of course, carry on, but I know that you're all getting hungry for lunch as well, the audience here. But I'd like to end on maybe a more optimistic and upbeat note, because it's always is the glass half empty, half full, 3/4 empty, 1/4 full. And it is easier to sometimes accentuate what is not working than what is working. And that's what Lee also said in terms of storytelling. Empowerment and empowering stories are the ones that really attract attention, sometimes more than the negative ones. So can we have a quick final round? Closing thoughts, or maybe one time in your career where you really felt that you saw the impact of the work that you do under the ICPD Program of Action, SRH for All, or a person that you have seen over the years who has truly inspired you, anything that really stands out for you that brings it home for each of you. And we can start wherever we want. Who would like to go first?
Like you, Roy, I think I'm feeling optimistic more than pessimistic. I think there's a lot of reasons to be optimistic, and let's see what Nairobi can come up with. But I do have a sense of optimism, although there are a lot of things that are not going right that we have to make right. about things that have impacted me in the last few years, which I see, unfortunately, because I was working outside my country, so I will not be able to give the Malaysian example, except for two. Malaysia took the lead role in something that I started before I retired. We look at nothing to do with sexual reproductive health. I looked at thalassemia prevention and control. And we were the first country to start the HPV vaccine. And our pap smear is becoming better now from 24%. I think now it's almost 60%. Ready to use the vaccine. We introduced the vaccine in 2010 for 13-year-old girls. And the coverage is very, very good. So I think Malaysia will be on the roadmap for the elimination of cervical cancer. So that's one example that I can give that Malaysia can take pride in. But one of the things that brings me so much of, what is the word I'm looking for? So much of, well, good memories maybe is, you won't believe this, Roy. When Nepal agreed to liberalize the abortion law, my maternal mortality went down. The first 6,000 abortions done by paramedics, by nurses, not a single complication. Nurses can do it. You just empower the nurses and put it in primary health care. But that's difficult for a country like Malaysia. And would you believe it? The Netherlands and the Swedish government gave me $9 million to do what? Save abortion in Bangladesh, a Muslim country. And I saw my maternal mortality plummeting. It was so heartwarming to see that. So I wish things like that can still happen. So my tenure in CRO, I think, yeah, those were the good memories that I have about the things that I did. And of course in WIPRO there were good examples. We did a lot of things in Mongolia, but unfortunately, I think, was there some polio cases in Papua New Guinea recently? Yeah. So we thought Papua New Guinea, because that was my highest maternal mortality, it was like 300, 400. But then it went down, and I had great hopes on Papua New Guinea. Then I heard this polio story. Back to pessimism.
Well, I think that being part of a regional organization and working with so many organizations, firstly, I remember that we worked with Reproductive Health Association of Cambodia, and it was a young people's program, and they actually went to their provincial governments and gathered the data, and they were able to get, services, from their local service providers, So that was really amazing, because you had these groups of young people who actually went and advocated to their local service providers, and they received them. I remember a case in Maldives. So we had a partner in Maldives, and we gave them very small funding, but they were so set. They said, we want to work with the ulama, and although in the penal code abortion is criminalized, but they managed to get the Ulama Council to pass a fatwa legalizing abortion. So, so these are like, sometimes they're the small steps, but it goes a long way, I feel, and it makes you feel, really great that we do the work that we do, and we know that everywhere, whatever small pieces we are doing helps that woman or helps that young person receive what they need.
Lee?
I think definitely coming from the media point of view, again, I have reason to be optimistic, because I think definitely we're seeing a lot more discussions and media reporting around this sort of issues, and hopefully through our continued coverage on these issues, it will bring about more awareness around the issues, and sometimes those also very small things, just conversations that we have with people. I mean, that's the great thing about being a journalist, because you talk to either the Prime Minister or someone who is just a very ordinary folks. In Hong Kong, I talked to a gay man, since Siva brought up LGBT just now, I spoke with a gay man who was forced to go through a conversion therapy, and he fell into depressions, and it was, this is Hong Kong. He had to go through conservative churches, so, but after, and he didn't come out to his family and friends then, but after conversations, I went back and I write the stories about him then, but what I didn't include in that story is that he actually sent me a text message after I came back to Malaysia and say, Lee, thank you for the chat. And, you know, after, you know, I thought about what we discussed, and I have decided to come out, you know, to my family and friends and let them know who I am, because there's no way to love yourself than to embrace yourself fully. So I think there are just all these great stories that need to be told, apart from discussing the issues. So I definitely hope to see there are more reportings on these issues, and always remember that when it comes to humanitarian stories, being whether LGBT, women's rights, gender equality, we cannot take the human out of humanitarian stories.
Thank you. And finally, some quick closing thoughts, Annette?
Having worked across the Pacific and in Afghanistan and Indonesia, I think that what I really wanted to share is that it wasn't until I was really working within UNFPA that I realized I had worked in sexual and reproductive health for many years, but it wasn't until I was working in UNFPA that I really realized how critical women's empowerment and gender equality really was to the achievement of sexual and reproductive health and rights. And working in Afghanistan, it became even more apparent how critical the women activist groups were to the whole agenda of sexual and reproductive health for women, even in the most rural areas. And I worked very closely with some of the women activists, as well as a woman called Dr. Seema Sama, who was the head of the Afghan Independent Human Rights Commission. And not only was she a shining example of how, in spite of the Taliban, she continued to do her work and work in refugee camps and deliver reproductive health services, but she also personally, financially supported schools throughout her province for girls to remain educated and to receive the best quality education they possibly could. I've also been inspired by men. And I have to say this because in our Indonesia country office right now, a young man called Dr. Sandip Nanawi joined us more recently, and he brought a new energy into the organization because his focus was all about the disadvantaged. And I say this because he started a home and he started a clinic and services for the most vulnerable HIV positive street children, street young people that nobody wanted to touch. And he took us back to the very fundamental reason of the marginalized concept. And I think that this has been really a very enlightening way for us to really think about the way we work in terms of leaving no one behind, but in reaching out to those that really are the absolute most vulnerable. Young people are not a homogeneous group, and getting down to the actual ones that are suffering the most is vital. We also, I found a lot of inspiration from working with our energetic HIV team, who worked with female sex workers and tried to take HIV prevention, diagnosis, and treatment to some of the most marginalized women, sex workers who don't even have an ID card to be able to receive health services. So I think that countries differ across the region. People are at different points in development. Disparities remain in our region, not just between countries, but within provinces, within districts. And I think that the ICPD 25 presents us with an opportunity to galvanize the global support and national support and civil society and bring together people to talk about how we can actually reach that very last mile by getting the most vulnerable and those that are furthest behind first. And so the for all for me is so important, besides the rights and the choices, so that we are really addressing the most inequitable situation that we have.
Thank you so much. And with that, we come to the end of the panel for the State of the World Population launch titled Unfinished Business, Ensuring Rights and Choices for All. I would like to ask the audience, before you go for lunch, if you can take 1 minute, if you haven't already. There is a pledge wall at the back which says, I pledge to ensure rights and choices for all. And you can sign your name there, or you can put a message, and we will indefinitely save it and frame it. So with that, thank you all over here, and thank you to the Facebook audience, and have a wonderful lunch. Thank you. Sorry, I'm told that you can't go for lunch yet until you ask some questions. So if there are any questions, we would be happy to take them. Feel free to stand up. There are some microphones there. And otherwise, you can mingle with us, and you can speak to our wonderful panelists as well. So are there any questions? I will hand it over to the Master of Ceremonies now. Thank you.
I'd like to address my question to any member of the panel, because in ICPD, one of the basic fundamental terminology is to provide accessible, affordable, available, comprehensive, primary health care and universal coverage, to the population. Of course, now we talk about marginalized. I'm so happy, Annette, at the end of the day, I hear HIV/AIDS being mentioned, because this brings me to the issue of integration. We talk about integrating the various aspects of reproductive health, but to me, I was with AIDS Council, and I've been with RH and maternal and child health for donkey's years. But the efforts to integrate services that were vertical is still something that is an unfinished business. And when we talk today about HIV/AIDS and looking at how it can be integrated into MCH services or reproductive health services, to me is still a challenge. And we talk about the marginalized groups. The way I see it now, the HIV/AIDS, although it is in the fore, but it is still very marginalized. And the drug users with HIV/AIDS and with teenage pregnancies or pregnancies. So if you look at the triad of one person getting the three phenomenon of what we say are the major aspects of HIV/AIDS, we haven't got, far much in that aspect. So how do we proceed to provide universal health care coverage and equity for all, especially those that we need to reach first?
Thank you so much for highlighting the issue of integrated quality sexual and reproductive health HIV services. I think the discussion around the essential package of sexual and reproductive health and HIV services is crucial within the context of the universal health coverage package. However, knowing that it's one thing to have the policy and the SOPs, the standard operating procedures, the guidelines and whatever, operationalizing that at the last mile, at the clinic level, is where we really need to think. And I think that there is commitment from governments to make this happen, but a lot more needs to happen to identifying who are the marginalized groups that are not able to get to those services. And it relates to the accessibility issue, the social-cultural determinants of accessibility that Dr. Narimah was talking about. And I think that you've hit on a vital issue that governments have to take on board and have to do a lot more, but it also needs civil society to be engaged. It needs the private sector to be engaged. It needs all health workers and across sectors to be involved. And I think this is something where the discussion has to become much more, rather than a top-down, but a bottoms-up movement that involves the community coming together to force and hold governments and health systems responsible for ensuring that they get the quality sexual and reproductive health and HIV services for all, not just for those that have ID cards for universal healthcare coverage, for example.
I think I just want to add to that. I think interventions to reduce stigma are really needed in many of our societies. So especially if we're looking at young people having sex and how do service providers treat them, what type of services they can so on. And even like, for example, very recently we had a forum where young doctors or young medical students said that I'm not going to treat LGBT people, right? So I think there's a real need to create awareness and conscientization of not only service providers but also health seekers and reduce stigma around some of these issues.
About the HIV, integration of HIV into reproductive health services, in 2009 we met in Guilin in China. Where is Josephine Sovereign? Now she's okay. So Josephine was the UNFPA representative for that meeting. We had a 4-day meeting. We came up with technical guidelines on the integration of HIV/AIDS and reproductive. You were not there though. Yeah, you were not there. But unfortunately, Dr. Raj, I'm sorry to tell you that I really do not know how well those technical guidelines are being used in countries or not. Then I moved to Searo, and in Searo we organized a meeting in Laos on PMTCT. That one, I can tell you, is a great success. So we did technical guidelines on PMTCT. We could see how many pregnant women were advised on, given health education on HIV, how many were tested, how many were positive, how many were followed up, how many were treated first, how many were followed up, how many husbands came. So we collected data on that. So that module was, and of course the top performers were Malaysia, Cambodia, and Thailand. So, I mean, it was something that really opened my eyes. For example, Laos, only 40% of the women came to antenatal clinic. But of the 40%, after 10 minutes of counseling, 100% said, yes, I will do the HIV test. No question asked. In one area in India, was urban area, well-to-do area, the coverage of antenatal was above 80%. Of the 80%, less than 10% agreed to have an HIV test. So that was very eye-opening for me. So we had to, we had to give interventions at every stage to make sure women are tested, they're followed up. Yeah.
Any other questions? If not, we're happy to wrap, and we can ask more questions later. If there is one more, we'll take it. Otherwise, anyone else? Going once, going twice, going thrice? Sold. That's a wrap. Thank you. Thank you all very much.
All right.